Well, good morning. I would like to introduce myself. I am a nephrologist. My name is Amelia Bernasconi, and I work in a public hospital here in VA. Our work, called Renal Response to a Protein Challenge in Patients with Lupus Nephropathy and Variable Degrees of Glomerular or Interstitial Damage After Maintenance Therapy, has no sponsorship, so no disclosures to declare. And for the non-nephrologist audience here, I would like to say that the renal functional reserve, we can obtain it with a test. What is it and why it matters? You know that nephrologists are always talking about creatinine, but creatinine is not a very good marker. So we are always looking forward to another marker. And we found that we can rely on this test. You know, creatinine is not confiable because it is influenced by renal factors and non-renal factors. Between the non-renal factors, the muscle mass, the age, the gender, the diet, and of course the nutritious status of the patient. But then we have another influences, renal influence, which is the tubular secretion of creatinine. So, saying that, I would like to say what this concept, renal functional reserve, means. And renal functional reserve stems from the observation that in normal humans, the resting glomerular filtration rate may be acutely raised following several stimuli. The kidney could raise its level of operation upon demands. That's to say that there is an extra renal excretory capacity. In a broad sense, this term, renal functional reserve, has been used to describe any increase in GFR, glomerular filtration rate, and renal plasma flow, following a variety of stimuli, for example, an infusion of amino acids. But usually, it is associated to an increased renal functional capacity that occurs as a result of changes in protein intake and more specifically to an acute protein load. It appears that when the kidney is damaged and it uses this reserve, the reserve becomes exhausted before the GFR falls. The assessment of renal functional reserve may provide an early measure of renal damage and could be used as an early marker of renal function decline. So you can think as this test as a stress test for the kidney, and we are showing you a dynamic assessment of the GFR. GFR, it is well known, increases after a protein load. This implies there is a reserve. This increment is variable, but in healthy individuals, it may be between 30 and 60%. It happens that in patients with a loss of nephronal mass, they may show glomerular hyperfiltration of the remnant nephrons. And in this test, you will have no response or a decrease in the functional renal reserve. So that's why we say this test could be an early detector of a decline in the renal function. We conducted our study following Buenos, who did the first studies in the early 80s. And you see in healthy volunteers, different ages, different genders, but on a normal diet, including meat, you see that after the protein load, there is an important increase in the GFR. We then conducted the study in pregnant women because I remind you that during pregnancy, there is an important hyperfiltration that lasts all the pregnancy. And we compared with normal women, not pregnant. We then concluded in an article in 2007 where we compared what happened to the pregnant women versus hypertensive pregnant women. And we concluded that both have a renal reserve, but the hypertensive one was not as high as the normal pregnant women. Finally, the renal response to a protein or amino acid challenge has major diagnostic and prognosis implications in the evaluation of progressive renal diseases, which is a frequent finding in patients suffering from lupus nephropathy. In recent years, the contribution of the tubulo-interstitial damage to the progression towards severe renal failure became increasingly apparent. Given that creatinine undergoes considerable tubular secretion, as I mentioned before, the assessment of sequential creatinine clearance after a protein load could serve as a test directed at identifying the magnitude of the functional tubular mass. The aim of this study was to evaluate the renal response to a protein load in lupus nephropathy patients with different degrees of chronicity index. So we studied 17 patients suffering from lupus nephropathy, 5 from class 3, 12 from class 4. All of them underwent protocol renal biopsy after 3.5 years of therapy with mycophenolate. As you see, 9 patients displayed predominant glomerular sclerosis, group 1, and 8 with predominant tubular interstitial fibrosis, group 2. They both underwent a protein load test in order to assess the renal functional reserve and correlate them with the biopsy findings. This is how we conducted our study. This is our flow chart, and you see samples are obtained and creatinine clearances determined every 30 minutes in 2 periods before the protein load and in 8 periods afterwards. Our results are clear. You see in the charts that both groups begin from the same GFR, but then we had a very significant difference between them. You can see it in the chart bars where it is an obvious difference between the 2 groups. In conclusion, the results from this study suggest that in lupus nephropathy individuals, the presence of tubular interstitial damage drastically reduces the renal response to a protein challenge assessed through the creatinine clearance, in contrast to the almost normal response obtained in subjects with predominant glomerular involvement. This decrease could be due to a fall in tubular secretion of creatinine as a consequence of a reduced functional tubular mass, or to a subnormal glomerular hemodynamic response due to a tubule glomerular feedback mechanism would altered. And finally, the reduction of the renal functional reserve should encourage to close monitoring of the population at risk. The assessment of the renal functional reserve may help to decide whether or not to discontinue treatment in those patients with abnormal response that suggest severe renal fibrosis, and in this population, treatment would be unnecessary. Further studies in larger populations should be performed in order to address this controversial and still incompletely explored issue. Thank you so much.
Thank you so much. The paper is now open for discussion. So how practical is to do this test in all our lupus patients? How practical is to do this test in our lupus patients with lupus nephritis?
It's a relatively easy test to do, but it lasts for 5 or 6 hours. But we are doing it as a routine in our renal unit.
So you're doing this in all your renal patients?
Almost, yes, single kidney patients, pregnant, transplanted patients, yes.
So if you do this in patients that have less advanced disease, because some of your patients has already glomerular sclerosis and significant chronicity index, have you tried to do it in patients with less advanced disease and see what happens?
Yes, we do. We are making the same in donors, and then afterwards we do it again.
No, I'm talking about lupus patients that have less severe renal disease as the ones you
No,
said.
we haven't. No, we haven't.
Okay.
Thank you very much for your exposition. I would like to know if there is any change among those people that are receiving enalapril, for example.
I'm sorry?
If there is any change among those people receiving antifibrotic drugs such as enalapril.
No, we haven't seen that.
Any other question? Okay, thank you so much.
Thank you.